there's at least a correlation between low testosterone and things like coronary artery disease, type 2 diabetes, colon cancer, in men, prostate cancer, osteoporosis. So there's reason to consider replacing some or most, even all these hormones.
Welcome to the Wits and Weights podcast. I'm your host, Philip Pape, and this twice-a-week podcast is dedicated to helping you achieve physical self-mastery by getting stronger, optimizing your nutrition, and upgrading your body composition. We'll uncover science-backed strategies for movement, metabolism, muscle, and mindset with a skeptical eye on the fitness industry so you can look and feel your absolute best. Let's dive right in. Welcome to another episode of Wits and Weights. Today's episode is all about hormones, peptides, innovative treatments with my special guest, Dr. Rand McClain. Dr. Rand will reveal the importance of testosterone, its effects on your body, how to manage them. We'll also examine menopause versus MANopause, the diagnosis and treatment of hormonal deficiencies, and we'll probably sneak in some questions from our community. Dr. Rand and I will also delve into the science of peptides, exploring their role in the body and practical use in treatment. And of course, we'll discuss his new book, Cheating Death. Dr. Rand has always been passionate about nutrition and wellness, which led him down an unconventional path to become an expert in alternative and progressive medical treatments. His remarkable journey includes serving as the youngest senior accountant in Deloitte's history, professional kickboxing, surviving prostate cancer, and pursuing medical school at age 37 despite skepticism from the status quo. Today, Dr. Rand's practice, regenerative and sports medicine, attracts A-list celebrities and world-class athletes seeking his innovative treatments. From the latest in stem cell and hormone therapies to IV drips that reduce trauma and anxiety to human performance health programs and futuristic longevity treatments, Dr. Rand believes that your past health mistakes don't define your future. Dr. Rand, it is an honor to welcome you to the show.
Well, it's my pleasure. Thank you. Thanks for having me.
Yeah, I was excited to have you on here. One of the themes of your life story resonates me, and that is defying conventional wisdom. That seems to be a common theme throughout your life. So we'll just touch on one of those, but feel free to expand. What was it like to go to med school in your late 30s? I'm in my early 40s, and I can't imagine just a few years ago having gone to med school. And how's that impacted your view of medicine, especially with, I think you call it the managed health, right? The modern managed healthcare system.
Well, there were pluses and minuses, as there usually are, right? In situations like this, focusing on the positive, I think I had a very different perspective going through at 37. First of all, I wanted to do it. I didn't do it because my great grandpa, all the way down to my pa, did it. And I didn't do it because I thought there was lots of money in it, because there isn't. I didn't do it because of anything, but I really had a passion for it. And I actually, the truth of it, I was traveling across country. I found out I was going to be a dad. And I said, I got to settle into something for good here, not just bop around. This is actually my 9th career, if you want to just talk about careers, not other odd jobs. So that helped out a lot. And then being 37 years old and eventually, by the time I got to see patients a little bit older, I'd been around the block a few times myself with injuries and illnesses and whatnot. And that helps, I believe, tease out some of the things where you go, okay, that's great, but I'm never going to really it reminds me of a joke. What do they call the doctor with the lowest passing score on the entrance exam? Doctor.
I don't want to touch that one. What is it?
Doctor. He's still a doctor.
Doctor.
I figured this is going to be the last time I go through this stuff, and it helped me pare down the things that weren't so important. I knew I was never going to be a dermatologist. I had no interest in dermatology, and so I remember getting mad when I scored. This can sound like I'm bragging, but it really was not. I got a 95 on the exam, and I remember thinking, "Gosh darn it, I screwed up because I overstudied." So the point being that the optimistic side of this is when you get down the road like that, you learn to prioritize and adopt perspectives differently. Who cares if you get an A or a B in dermatology if you never want to be a dermatologist, And it allowed me to focus on the things I really enjoyed and I knew I wanted to pursue. And I think that was an advantage. Also, look, we all deal differently with people when we're 20 than when we're 30 and 40 and whatnot.
Sure.
And that helped out a lot, just going through internship, dealing with patients differently, and having been a patient, that gives you a leg up. Now, the negative part of all that is at 37, you're supposed to be doing pretty well financially, and you should have a lot of other things going. I ended up going through this as a single dad at one point. I spent the nights in my van, up at school and whatnot. And that part of it was not so fun. Although, again, being a little bit older, it's going to sound trite maybe, but it is absolute truth. I can remember I finally I was able to afford a place, which is actually just a couple blocks down from where I am in my office now. They used to be Marine Corps officers' barracks, just one room deals. And I can remember sitting out there in an afternoon and, I had an hibachi grill, those cheapo things that I think even in a CVS now. And I was cooking up some hot dogs and some baked beans. And a lot of people go, whoa, God, roughing it, huh? And I remember thinking, I'm really not. I'm in California, the sun's out, and I like hot dogs and baked beans.
Yeah.
And I'm thinking, all right, well, this isn't so bad. And of course, the take home is, and again, this is going to sound corny, but following your dream, that makes a lot of the things not so bad. And that's what I was doing. So yeah, I had some good experiences and some not so good, but it all worked out.
Yeah. And that really resonates with me with the later in life that people ask me, for example, as a nutrition coach, how could I be a good client when I didn't start this, or a good coach when I didn't start this in my 20s? I said, well, I've dealt with so many people, both as a father and as a manager in the engineering world, that those skills translate. And you've got this unique perspective that no other person in med school with you at the time had, that I'm sure translates to this day as you work with your patients. 9 careers. Wow. So, you talked about the surgeries that you had, or the personal experience you had gone through. And I think you talk about that in your book as well, in Cheating Death. If I could just quote it real quick, because I did get an early copy. I was able to peruse that. You said you're, quote, alive and well, both because of great doctors and surgeons, and because you've been open to a wide range of treatments. And I think your message about health span is partly about having options, maybe options beyond what people think are there. Right. And I've seen people fail my clients. I've seen people fail my very close family members time and again over the years, because there's this myopic view, I feel, that most traditional doctors have, and they have to go out and find other treatments, alternative therapies, hormone treatments, specialists, coaches, et cetera. What are your thoughts on all of that?
Well, I think the point I'm trying to make in the book, or one of the intents of the book anyway, is to get the word out that there are other avenues than what most people think. Even if you're pretty much in touch with medicine, if you're not a doctor or you're not reading the journals every day, you're going to get behind. And even doctors get behind, because we are very specialized in what we practice typically. And that's just a matter of, we have so much information that we have to gather and learn. And then, we have to be proficient in that area. We always talk about, the gatekeepers, the primary care providers being the ones that sort of collect all this together. I can't think of a better way to do it. You can try and you should always be your best health advocate, but unless you've been trained in medicine, trying to do that over someone who's already been trained in medicine to play that same role is going to be harder to do. You can't do it. But
you just to clarify, you're talking about the scenario where you go to the doctor and they kind of have that holier than thou kind of air about them, and you are the kind of the dumb person doing the internet research. And I'm very much simplifying, but these are real people's kind of thoughts about this subject. Yeah. And I, even when I talk to my family about it, that's kind of where you're going with this? Hey listeners, this is Philip Pape, and I'm excited to announce our upcoming totally free 21-day challenge starting December 1st. It's called the Wits and Weights No Diet Holiday Body Recomp Challenge. This challenge is about learning how to achieve body recomposition. That's building muscle and losing fat at the same time without dieting or restriction throughout the holidays. I'll be giving you free videos, guides, and personalized coaching in a private group chat to help you enjoy the holidays while being satisfied and guilt-free. The kickoff call is Friday, November 17, and the link to enroll is in the show notes. No matter what episode you are listening to, don't worry. If you're hearing this after November 17, you can still register and get access to the replay and resources before the challenge starts on December 1st. Again, to join the Wits and Weights No Diet Holiday Body Recomp Challenge to build muscle and lose fat without dieting through the holidays, click the link in my show notes. Now back to the episode.
Well, and I can make a joke. You're being redundant when you say, godlike and doctorish. I mean, that's the old school way, the very
Yeah.
paternalistic way
Yeah.
but it's still pervasive, obviously,
Hmm.
because we speak a different language. Although that's changing, man. One of the things that's
Sure.
a good offshoot of the biohacking, although there's a lot of negative consequences we've seen, certainly a lot of possibilities where you can go wrong, but people are getting interested in it, doing a lot of learning on their own, and again, that comes with pros and cons. Dr. Google is not always your best source, but
Hmm.
it's changing the environment. So patients are a lot better educated. They have a lot more information. So it makes it easier for a patient to push a doctor who might be gaslighting them or, playing that God thing, which again, I joke is redundant. But no, that's the point I'm trying to make. And really the whole idea of the book, again, is to let patients, and without sounding like I'm a jerk, doctors also know it I don't think I'm sounding like a jerk because I preface it by saying, our profession is such that we're specialized. Why would an expert in skin cancers, let's say, know anything about, I don't know, ways to reduce blood sugar?
Right.
We learned in internship. So I don't mean it the way that might have sounded, but the idea is to get the word out so kind of everybody can be the gatekeeper and at least have a little bit of knowledge about, when I see this, I don't have to focus on this necessarily only. That is my job. That's my specialty. But by the way, you might want to see a rheumatologist about this or whatever. And also, the other point that I think you're asking me to address is because it's changing so fast, I make the point in the book that I missed out on a lot of treatments because I figured, to use the spine as an example, I'm either going to have to get this fused or I'm going to put the equivalent of a door hinge in there, and that's not going to work for me. So I'm just going to gut it out for as long as I can. 33 years later, it got so bad that, the guy pretty much told me, well, first of all, the MRI doctor, the radiologist chased me out in the parking lot. Said, "Hey, man, do you realize what's going on here?" And then the surgeon said, basically, I need to do this yesterday. So I don't want people to get to that point because then you've limited your options as I did mine. And so if I can get the word out that, hey, we have this option, this option, and this option, and you mentioned futuristic treatments. Yeah, they sound futuristic to most of us, but they're here.
Just need to catch up.
So
Yeah.
that's what I want to get across so that we manage our health and do it, with all the options we have possible.
Right. Yeah. And part of what you said there was, not every doctor comes from the same place, and there are definitely some better than others. There are some that stay up with the research versus others. I used to have a primary care doctor years ago, and I know people like to, talk down about primary care physicians who taught and studied, and he was always open to, every time I brought something up, let's explore that together. And I love a doctor like that. And what was the other thing you mentioned there that I'm kind of losing track of here? How things change over time, right? Like laparoscopic surgeries and things like that. I had 2 surgeries 2 months apart a couple of years ago, one for a microdiscectomy and one for an appendectomy, both laparoscopic. I can't imagine having done both of those surgeries, 30, 40 years ago at all, let alone 2 months apart. I want to just last personal question, then we can get into maybe the listener wants to hear all about the hormone stuff. What does your personal daily routine look like when it comes to your lifting, your nutrition, your wellness?
Well, I'm what they call a morning lark, right? In terms of chronotype. So if I don't get it done early, it ain't getting done typically. So I start the day with a breakfast. Mine is pretty much bacon, eggs, and toast. If it's a special occasion, my wife will make me pancakes instead of toast. Usually put a little almond butter or something on there. But then I get into my workout, which will be either weights. I'm getting ready for my next surgeries. I've got to get 2 new shoulders. And I mean that. People say, "What do you mean you're training for your surgery?" Yes, I'm getting in shape for surgery because you only come out of surgery in the same fitness or less, right, by a day because you didn't train that day. Then you go in. So I've been hitting the weights a little bit more, but I love bike riding. I still love, I don't like getting in the ring anymore because of my spine, but I love, training as though I were a boxer. So I hit the heavy bag. So I get my morning workout in, and that's usually anywhere from as little as an hour if I'm doing VO2 max stuff, or, can be as long as 3 hours. And I post all my workouts on, Garmin Connect so that I can share that with really anybody, in a, hey, we're all in this together way, keeping ourselves honest. Then I'll see patients on certain days. I'll have my lunch. And really after that, it gets boring. I mean, for most of the listeners, actually, they might be bored with the first part, but after that, I feel like once I get the workout in, which I believe, and I think I hope I make this point in the book, exercise is what I call the great equalizer. I've done not the most I can, but one of the best things, if not the best thing I can from my health span, and gotten that out of the way. And from there, it's gravy. So, and then I look at, I see patients. I got a few other businesses that are related to medicine I work on certain days. And then I'm out usually before I make it upstairs, after dinner. And much to my wife's chagrin, because she likes watching shows and stuff. And she's actually a night owl. Not that you have to hear any of this stuff, but
no, these are all fair points because people relate to okay, you're a man of routine, which is good.
Yeah, it's life.
Yeah.
But you know what? I say it's boring. I love it. If I can get my workouts in, some good food and good company and that sort of thing, and then get my job done, which I'm blessed because I get to see patients and I love what I do. I don't see sick people. So that makes my job a lot easier. I've already found I take it too much to heart when I see somebody really, really ill, and there's limits as to what you can do when someone's taking 26 meds and they've got 3 or 4 comorbidities. I'm just not cut out for that. But yeah, and we live here in Southern Cal. Can't complain except for the taxes.
Right.
Yeah.
Oh, I'm in Connecticut, so I can complain about the weather and the taxes. I hear you, man. All right. Okay, cool. It's good for people to know this. I mean, you do lift and you stay active and eat eggs and bacon and all that great stuff. And like you alluded to, fitness and movement, exercise is 80-90% of the equation. And if you're not doing that first, maybe these other treatments are the next step after you get those things dialed in. So speaking of some of these treatments, let's start big picture. Testosterone, something men and women are interested in. Why is it important? Let's just start there, big picture. Why is it important? And then what are the signs of low testosterone?
Well, I always joke, and it dates me with those who are of similar generation, that, it almost sounds like we're trying to make it out like that Saturday Night Live skits for Shimmer. It's a floor wax. No, it's a dessert topping. But in some senses, it really is that important, testosterone anyway, for males and females, because it's responsible for so many things. It leverages your energy, your sense of well-being, your libido, your body composition. And, tell me there's not at least one of those that everyone's interested in, right? Mm-hmm. And I'm naming a few of them. So that starts to diminish the production of it in our bodies somewhere around age 35. Whether it's referred to as menopause or andropause, that's when it happens in men, and ditto for females. Perimenopause actually is the way we put it, paraandropause, and it's noticeable. Some people do better with it than others. We've all met the guy or the gal that is bouncing off the walls with energy, right? And that's not their problem. No matter what happens, they could be 90 and have low testosterone, they're bouncing off the walls, but that's personality based. But the dead giveaway, you can say energy, libido, sense of well-being, that good mood, that's driven by personality, certainly. But body composition, you can say, well, yeah, that's also, genetically based. Okay, given that too. But that's where people who otherwise are doing well come in and see me. They go, okay, I'm doing everything. And a lot of times it's the professional athletes, right? They're like, okay, they're the last ones because they know all the tricks. They go, okay, well, I pulled this out of my hat. I pulled this out of my hat because I know.
Yeah, the training, the nutrition, the everything.
Yeah, and they keep tweaking until they're finally like, okay, I'm done with this, man. You got to help me out. I pulled everything out, and it's just too much work, or I'm not getting there anymore. And so I tend to see them later in life than say the so-called average person. But testosterone is important for all the above, and then for females only. Although having too high or too low estrogen affects males too, but more directly because of the body parts and the way women are designed to use those body parts. Estrogen deficiency can affect women pretty significantly. A deficiency can cause anxiety and palpitations, the classic, night sweats and hot flashes, and eventually vaginal dryness. So, there's a lot of reasons to look at hormones. The less sexy ones, DHEA, progesterone, pregnenolone, those are important too. And they all start to drop off. There's this cascade of hormones that starts with cholesterol. They're called the steroid hormones from the word cholesterol, and they're all steroids. not anabolic steroids, which is where the confusion comes in, I think. And by the way, it includes vitamin D. People, I think, are realizing that more and more. Again, the biohackers and people that are paying attention.
Yeah.
We named it in the late 1800s, I believe, and we thought it was a vitamin. No, it's a steroid.
It's a misnomer, yeah.
Vitamin D. But these are all important, and why not replenish them, replace them if we can? We cannot get the body, at a certain point anyway, to make them again on their own. So fortunately, we have the ability to replace them, and it's been a game changer. Death and taxes and deficiency of hormones is eventual. We can fix at least one of those. Two of those we're working on, at least in terms of state taxes, right? I think we talked about that for the show. But yeah, definitely something that is a game changer. And that's why I think I have a great job, because I see a lot of happy faces.
Yeah, I imagine. And what I've always wondered, though, is like, first of all, has anything changed in the last 50 to 100 years that causes the decline in some of these hormones to occur more frequently or earlier? That's the first question. And or is this just a natural state because we live such long lives and it happens to just about everybody? In other words, there's nothing wrong with you per se, as this is just going to happen.
It's both.
Okay.
Great question, because typically it happens to all of us. Like I was implying with, the death taxes and low hormone statement, that, if you live long enough, you're going to notice it. Correct. 300 years ago, life expectancy was, depending upon what, estimate you read, 30 to 35 years old on average. Well, what are you worrying about? That and, malignant melanoma is probably not going to be on the list either. You can stay out in the sun as much as you want. You're not going to get wrinkles or malignant melanoma. So they were enjoying it. There was no sunscreen back then. They weren't worried about it. But yeah, we're living longer, so we're going to experience those things now. But also the way we live, just going back not thousands of years, just again that 300-year span there. 300 years ago, we're herding sheep. Mm-hmm. Every once in a while, a wolf might come in, and you got to get your dander up, so to speak, or an opposing tribe, which is more of an issue maybe. But you didn't have the chronic stress. You didn't have the necessity of cortisol manufacture and it floating around your bloodstream, which hammers you. And that affects pretty much chronic cortisol release, pretty much is a detriment to everything we got going for us. Yeah. And that is a cause of earlier rather than normal or later, whatever you want to call it, hormone deficiency.
Yeah, I'm glad you mentioned that, because covering the gamut between the reproductive hormones and then cortisol, and I think you mentioned thyroid, they're also critical. So what would you say to the statement, if you can get your diet, nutrition and lifestyle dialed in, you probably won't need hormone replacement. Is that a false statement for most people?
Depends on how long you live. If you live long enough, you're probably going to be better off on hormone replacement for two reasons. One, even if you're not suffering, meaning, the testosterone drops and she has, less libido, but she's also divorced, let's say, or never met someone she wants to stay with. Who cares? No one's bugging her. She doesn't have the libido because the levels are low. And in every other area, she's fine. You could argue, because we treat people and not numbers, don't worry about it. Then she could live a full life. But we've connected more dots than that. And we can say, even if you're doing well, meaning you're not complaining and you're happy with it, there's at least a correlation between low testosterone and things like coronary artery disease, type 2 diabetes, colon cancer, in men, prostate cancer, osteoporosis. So there's reason to consider replacing some or most, even all these hormones. And I'm talking about the steroid hormones now. You mentioned thyroid. That's a whole nother, that's a protein-based hormone.
Okay.
But even so, the idea that you treat people, not numbers, there's sometimes where you might want to treat it just because it's low, because it's going to be better for your health span anyway. It tees you up for a longer, healthier life, with emphasis on the healthier part, rather than being sort of caught by surprise or caught too late.
Okay.
So, yeah.
I think it's a good way to look at it. And I don't know if this is an apt analogy, but that's kind of how I feel about strength and building muscle, is that, you could be 30 and feel like you're fine and capable. But if you don't build that muscle mass as a matter of course, it's going to catch up to you. You're going to get weaker, more frail, and then it's going to lead to all sorts of health issues as well. I mean, I think there's multiple things in life like that in the area of wellness that the more proactive you can be, which is harder when you're not dealing with an issue or when the industry is telling you, well, there's nothing wrong, so don't worry about it. Go to a doctor when you need something fixed, right? When something's gone wrong. So I think that's a good message, Dr. Wren.
There's a couple things you did there in that statement too. One is that, again, if you're muddling through with less and less muscle mass, and implied in there is that you're going to have less and less strength too, then okay, that's fine if that's what you feel, but you're definitely not the same as you were when you were 30 at 60. And just because you're saying, well, I'm okay with it, doesn't mean it's okay in the sense of, measuring your physiology, apples and apples. So, you're definitely, for example, more likely to suffer from osteoporosis, or there's a huge correlation between muscle strength, muscle mass, and of course, VO2 max. So there's no debate about that anymore. So you're definitely cutting yourself off at the ankles at least, or the knees, maybe, if you don't stick with it. And you do have to stick with it. That's the point. There is sort of a cat by the tail there that's necessary, just like we have to eat and breathe and a lot of other things. And then there's another thing you were starting to harp on there that, I like to hopefully make people laugh, but I'm serious when I say it, normal. Okay, yeah, I feel like, this is the way my father or my mother lived when they were 60 or 80. It's normal, and I accept these things. Okay, well, that's your prerogative, okay? I'm a registered libertarian. I wouldn't argue with you in that sense, but it's normal to get sick and die one day. So who cares about pursuing normal for the sake of normal anyway?
Yeah. It seems like the best things in life are both hard to achieve and also make you an outlier, and those are the things we want to pursue. I don't know if you agree with that statement, but and once you put in that effort up front, it actually makes everything else easier down the road, whether it's treating your hormones, getting stronger, or whatever else. So speaking of the diagnosis and treatment, I'm actually curious on the diagnosis part, because now that the context is you may not have any issues, right? You may not even have symptoms, but it's still good to treat it. How do you diagnose it in that context? And then we can get into treatment as well.
Well, great question, because it takes it a step further. So you have a patient, let's say, let's take a 55-year-old female. And I picked that because with osteoporosis, a female's just statistically more likely to have osteoporosis than a male. Okay. She's happy as a clam, has no complaints, except she's got osteoporosis. Okay, well, you can draw labs. You can see, oh my goodness, she's not only low in testosterone, but she's also low in estrogen. Even if she doesn't have any complaints about estrogen deficiency, a lot of females sort of dodge the menopause bullet to a large degree. But she's also diagnosed with osteopenia, or worse, osteoporosis. You can take some Fosamax. You can add a bunch of calcium to your diet, and therefore suffer from constipation, I would argue. Add vitamin D if you're not on it already, and see if that helps. Of course, weight-bearing exercise is always very important to stave that off, but I've seen many a time where you've got someone who's active. She's 55-year-old female, and unless she wants to pick up Olympic lifting or powerlifting, she's doing plenty of weight-bearing exercise, but she's still suffering from this. Well, you can add estrogen and or testosterone and help with that diagnosis. Now, again, there's not a direct correlation between symptom and treatment in terms of what's classic, but a lot of times it is a lack in sex hormones, the steroid hormones, that leads to, or certainly contributes to osteopenia and or osteoporosis. Does that make sense?
It does. Yeah.
Yeah.
And even worse is when someone does have symptoms and then the kind of conventional medicine says that there are no options. That can be very frustrating for people as well.
And that's really why it motivated me, because I am sick of hearing that, of course, personally, but I see it in patients that are told something from another physician. And come on, if you're passionate about what you do, whether you're a doctor or say trainer, someone where you're trying to help somebody with their health, and you hear something from another practitioner that's just complete completely bogus. It kind of chaps your rear end, doesn't it? I mean, be honest.
Yeah.
And so, I got to get this out there to counter that at least, if not straighten it out. So, that's something you see all the time. And it's really discouraging, obviously to the patient, but as a physician to me too, because you see someone who really, really wants to do something, wants to get better, and they're getting advice that's just, again, completely bogus. It's very frustrating for a lot of parties, right? So.
Yeah, and even just as a human being, just in any pursuit, someone who just has that either apathy or dismissiveness, if you will, and I'm sure there's a lot of factors behind it, but we don't have to get into that part. Let's get into the solving problems for people, which is what you do. And we talked about being treated for hormones could be a good thing to pursue, regardless of maybe all the symptoms. How do you treat those hormonal deficiencies? And I want to get into, of course, bioidentical hormone replacement therapy, traditional therapy, kind of comparing those, and then common misconceptions, one of which, of course, is, it's going to cause cancer. We know that people still think that, so I want to understand your perspective.
Well, that's a broad question.
It's a compound question, sorry.
Well, no, but fair enough. It depends upon the hormone, of course, that we're talking about that's deficient, or in some cases, excess. And we deal with them all differently. I alluded earlier to the fact that there's a difference between I call fat-based or cholesterol-based hormones and protein or peptide-based hormones. You got the thyroid growth hormone, other peptide, insulin. Those are the protein-based or peptide hormones. And then you've got the steroid hormones we already mentioned. And they work differently, that's for certain. And testosterone, I will say, is unique in that, unlike, say, thyroid, where you're looking for a sweet spot, you don't want it to be too high or too low. With testosterone, more or less, you're looking for a minimum threshold at which you want to remain or stay above. You don't want to go miles above that or anything like that, but the emphasis is on don't drop below that, because you will become sub-therapeutic, okay? And there is some linearity once you become therapeutic until you go to, if there's such a thing as too high, there is. But it just, again, there's differences in the way you treat hormones depending upon which ones we're talking about.
Let's take DHEA, right? For example, just to throw one out of the hat. I've seen, the over-the-counter stuff is, sold in 5 milligrams, 30 milligrams. So there's obviously a dosing difference. How would you help somebody treat DHEA?
That's a great question. Let's use DHEA. Great. Let's start with one. So there's an old rule of thumb that for each year on the planet, you use 1 milligram of DHEA. I don't know where that comes from. I don't subscribe to it. But the problem with some of these hormones, and DHEA is a great example, is you've got this hormone that you want to do certain things. And by the way, it has certain other effects because of its ability, the body's ability to interconvert depending upon what's necessary. Okay.
To testosterone in this case? Yeah.
What's that?
Is testosterone in that cascade?
Yeah. No, because testosterone's further down, but there's kind of like, it's like a little triangle, circle, whatever you call it, where it could go down the corticosteroid route, or it can go down what we call the sex hormone route, because it includes testosterone and estrogen. And there's a lot of other androgens that we don't talk about that are, intermediates, but also have effects in and of themselves that can be converted from DHEA. So I always use the quick example, do you want to go from LA to San Francisco via New York, or do you want to take the straight shot? And in the old days, as they say, a lot of times, particularly with women who were suffering from lack of energy and libido and whatnot, doctors would prescribe progesterone in the hopes that it would convert to the necessary testosterone and or estrogen if needed. And this is really, we're talking about mainly OBGYNs, because they were used to using progesterone and estrogen to treat the organ, the uterus. Okay, so they're very comfortable with that. They say, we'll treat it with progesterone. I'm going way off on a tangent, sorry, but back to DHEA. Yeah, and this delves into why we're classifying DHEA as an over-the-counter supplement, but testosterone not. You got me, because you can do a lot of things the wrong way with DHEA. For example, as you point out, it can convert to a lot of different things down the line, testosterone being one, but also estrogen, which may not be appropriate for a male. And so you're kind of rolling the dice there with each individual because they may convert it differently than another individual.
Okay.
Apropos to DHEA, I like to supplement with one of the 3 metabolites, 7-keto DHEA, which isn't normally assayed, but that will not typically convert to a hormone you're not looking to use. So you can, if you really want DHEA in the system, plug it with 7-keto rather than DHEA, which can either remain in the serum or convert to DHA sulfate. But those can run into trouble that you don't, by converting into things you don't necessarily want. I'm giving you way too much information on it.
No, I can nerd out on this stuff for hours. And I think maybe a lot of the listeners too. That's the cool thing about podcasts, right? Was we can get into this stuff. But that's something I learned right there is, like you said, there's downstream effects. So be more targeted, right? And work with people who understand this stuff like you and others like you that can help you, target the treatment. So you mentioned creams, right? Like estrogen, progesterone. I mean, there's testosterone creams. There's all those. I actually have a question from one of our community members, Christine Y. She was wondering if you should stop all the creams once a month to help the receptors, recover and avoid getting oversensitized or desensitized.
Yeah, that's a great question. And I hear that one often. I don't know where that came from, but the idea that you're going to desensitize the receptors, I think maybe stems from the idea that you can actually downregulate some of the receptors. And it's really more of a result of reversing an upregulation. So when you're short in hormones, this is the fascinating part of the body, right? Your body's not making enough keys for the locks. So it says, all right, well, we're going to make more locks for the same keys. Brilliant, right? And then all of a sudden you use replacement therapy, you got plenty of keys, and the body says, okay, whoa, we don't need this much. And so it'll downregulate some of those locks, the receptors in this case. And, there's some downregulation we understand when you overdo it, if you're normal, so to speak, like somebody who's 25 years old and decides he wants to cheat the system, whether it be bodybuilding or or whatever.
Metabolics, yep.
Then there can be some downregulation there. But for someone who's using testosterone replacement therapy, the key being it's to replace what's no longer being produced, right, naturally, then, yeah, the idea of coming off to upregulate the receptors doesn't make a whole lot of sense to me, because while you may get some benefit in terms of the way you feel because, oh, wow, you've upregulated them because you're short for a while again, it's temporary, and you're robbing people to pay Paul, right? But I do hear that a lot.
No, that's good. That's good to clarify. And it actually sounds a lot like the same kind of downregulation that occurs during metabolic adaptation when you're dieting, where the idea is that you're damaging your metabolism, which is not true, because as soon as you go back and feed yourself, it recovers. So the body's resilient is what you're saying. It's good for people to know this and not get scared off from some of these maybe misconceptions. Okay, so let's because I know we got started a little late, but let's I want to talk about peptides. Yeah.
I love
all right.
Because that's coming from the audience, right? You're listening to people that they have the sort of, I guess you call them one-offs that, we may not think about because it's kind of not mainstream, but that's a common question actually. And to just the bottom line it, no, do not go on and off. It's not going to be the benefit.
Keep doing it while you need it. And there you go. Hey, this is Philip, and I hope you're enjoying this episode of Wits and Weights. If you're finding value in the content and want to stay up to date with all our latest episodes, be sure to hit the follow button on your favorite podcast platform. By following, you'll get notified whenever a new episode comes out, and you won't miss out on knowledge and strategies to level up your health and fitness. All right, let's get back to the episode. Actually, there was another question from a different Christina M. She was asking if there's a combination of supplementation with adaptogens, vitamins, or herbs you would recommend in any scenario. Kind of a high level question, I know.
Well, if I'm reading or I'm hearing that right, she's referring to what I refer to in Chinese medicine terms as what would be called a superior herb, one that's not used to treat a condition, but is something you could use all the time because it just makes you better. Ginseng is one that people refer to as something you can take, unless you get sick. But generally speaking, it's good for you, right? Is there one out there? I'm not big on formulations, even though Chinese medicine is loaded with them. You have some of those ancient formulations, and I'm too far removed from it now to be able to recall some that I'd say, oh yeah, this is a brilliant one. Keep doing it. There are some that involve use of Hersha Wu, which is generally speaking one of those that's going to only be good for you. It restores what they call kidney yin, if I recall correctly, which really kind of boils down to hormonal balance.
Okay.
But in terms of what she's asking, I'd rather take an adaptogen, Siberian ginseng, and combine it with whatever vitamin I'm looking for. I think I'm short on vitamins, and make my own formula.
Yeah, I get it. Yeah. Which is consistent with what you were saying before. Is like, don't just throw everything at it. Go after what you need. What about ashwagandha? I wanted to ask you about that. What are your thoughts on that?
The question I get often is that going to be a substitute for testosterone replacement therapy? No.
Well, I'll be specific, right? Because I understand in the lifting world, it's being looked at as a performance enhancer, and then also in kind of the hormone support world for things like mood and anxiety.
Mm-hmm. Very individualized, and I would call it, speaking of Chinese medicine, which deals more with subtleties, the result would be more subtle. It wouldn't be something I'd say, oh, forget about it. But I think that you might find a lot of times when you're supplementing, you're replacing what's missing. And that's why, like I use the example of vitamin B12. If someone back in my day we didn't have vegans, but they were called vegetarians, right? And so they weren't getting enough B12. And they did some B12. Oh my goodness, they were elated. They were nuts about B12, and they would go preaching about it, right? Well, as a carnivore, omnivore, I think B12 was like, what is all the fuss about, right? Because I wasn't short in it. And so that's, I think, where you see a lot of individual differences when people try a supplement. Oh my God, you got to try this, it'll work great for me. Okay, well, so I'm not downplaying ashwagandha at all, or any particular supplement. But if you need it, great. There are very few that are going to put you to the next level, or take you to the next level, is a better way to put it, I guess, if you're already in good
makes sense.
That makes sense.
Yeah, you're already saturated with it, or whatever you want to say. You have what you need.
Like the classic example is immune boosters, right? Really, what's happening is you're bringing your immune system back to its regular state that you've been somehow diminishing by staying up too late or drinking too much or whatever. So that's the classic example. So when you hear that kind of stuff, it's an immune boosting supplement. I would use some skepticism in doing that, but I think we're going to find more and more we'll be able to, at least in the short term, tweak some of those by more just stimulating it back. Still, though, by stimulating it back to its normal, better state. Rapamycin is a perfect example of something like that, where in general we're stimulating autophagy. Rapamycin is a drug. I'm sorry, I just took a huge turn and tack here.
I've heard of it, but
rapamycin is a anti-rejection drug. Okay, they use it, kidney transplants, right? In higher dose and more regularly. Well, we found now that, at least in animal studies, and it all looks good for humans, that if you use a smaller dose and punctuate the week with it just one time, it's enough to stimulate this process of cleaning up the mess, as it were. Autophagy is where we go in at a cellular level, clean up the mess that's been created, reorganize things. I call it, wipe the spaghetti sauce off the recipe book so you can actually read the recipe again. Reorganize the DNA, right? So that the cell can operate properly. Well, that's really the idea here, is that you're just getting the immune system to operate at its best again by sort of just giving a little nudge, if you will.
Sure.
And I'm being very broad and very general, but the idea is the same.
Yeah, no, I love that. And I mean, I'm sure you can examine that in the context of vitamins and minerals and other nutrient deficiencies and all that, where, again, if you need it and you take it, it is going to be kind of like a miracle. I've had people who start taking magnesium and their migraines go away and they sleep better and all these, just because they were deficient in that one nutrient.
But doesn't that make it fun?
Yeah. Because does make it fun.
It's just knowing about it's worth a try.
It's a solution, yes.
Magnesium's not going to hurt you. I mean, really. Yeah. If I might, just because magnesium is pretty, it's top 3 in my experience of being low when we check. But you give intravenously to a woman who's in labor and you're trying to quell those contractions. Every 15 minutes, we give 6 grams intravenously. That's the equivalent of oral 60 grams, okay? But every 15 minutes. Now,
Yeah, no, that's a huge amount versus a pill, which is like a half a gram. Yeah.
Right. But if you left it going for a couple of days, you might have a problem. But imagine trying to do that orally. You can't overdose on magnesium, right?
Right. That'd be 200 pills.
Some, very, very, very loose stools, right? And maybe, because of that, you can get dehydrated and all that kind of stuff. But you get my point that they're not innocuous, but they're very hard to make a mistake with. So it makes it easy for us to knowing that, oh, wow, that might, we study, that might be a cure for my migraines, some electrolyte balances there. Gosh. And what are the other upsides? Because maybe it doesn't fix your migraines, but it's going to help, relax the smooth muscular vasculature so you get more blood flow to the muscles, help relax you a little bit, keep you a little looser. Nothing wrong with getting more blood flow to the muscles, right? Only good things. So that's what's exciting to me on the very basic level with what we know now in medicine, what we can do with it.
For sure. Yeah. And you mentioned skepticism earlier. Skepticism and experimentation, they all kind of go hand in hand. And that's what we're all about here. So you're inspiring me too to keep digging in and making sure I've got all my bases covered. In fact, I think I started taking more vitamin D again. I had gotten off track there a while, and then I was reading through your book and reminded I probably should up here in the Northeast during the winter.
Well, not only that, I don't know if I mentioned in the book, but going back to that example about 300 years hence, if you were going to be dead, typically on average, by the time you're 30, 35, you weren't concerned about the sun vitamin, right? Getting your vitamin D from the sun, because you were going to be long gone before you had a chance to develop malignant melanoma, which can kill you. Nowadays, we're living a lot longer, so that is a risk. Trust me, because I last time I had 36 of these puppies that had to be removed, right?
Yeah, you got a nice tan. I imagine it.
And I moved to California, and I didn't take care. We didn't know any better. And honestly, even when we did, I didn't do what I was supposed to do. My fault. Sure. But the point is that you're going to live longer is the anticipation here. Let's be optimistic. So we can, better living through science, take a pill to get that same vitamin D without exposing ourselves unnecessarily to the radiation that can cause a problem. Let's do it. I'm not saying stay out of the sun. Just wear your sunscreen when you go out there, and then you get the best of both worlds.
Yeah, good point. All right, let's turn to peptides. This is something I don't know as much about as I want to. Reading your book, learning about it. I also have a collaboration with someone. She's opening an aesthetics studio where they're going to offer peptides. So it's starting to learn about it. You said that 10% of pharmaceuticals are based on peptides and proteins. Creatine's a peptides. Yeah, I wasn't even aware of that. Of course, I take that every day. Anybody who lifts should be taking their creatine.
Along with beta-alanine.
What's that?
Along with beta-alanine.
Yes, which is often found in pre-workouts along with like L-citrulline and what's the other one? Betaine, I think are the big three, but beta-alanine, that's... The
reason being is because you're going to extend your time to exhaustion by 3 to 5 seconds minimally with the creatine, and that creates an acidic environment that the beta-alanine will balance.
Okay, well, I'm glad I take my beta-alanine in the pre-workout, so there we go. Knew there was a reason for it. So yeah, anyway, peptides. So there's a whole bunch of them. Even in your book, you list just a wide variety. Growth hormone, gonadotropin releasing peptides. There's some for libido. There's collagen. In layman's terms, give us a crash course in peptides and then how they work in the body.
So peptides, really it's a matter of semantics, because depending upon who you talk about, most agree that 50 or more is a protein, 50 or fewer, I guess I should say, is a peptide. But all they are, so you've got these amino acids in a certain structure. And I liken it to Tinker Toys, right? Where if you remember that, I don't know if they're even still around, but you have...
I played with them in the 80s, so yeah.
You can pick the structure you want. And just one ligand different, one extra post with another knob at the end, we'll call it with Tinker Toys, can change the way it works dramatically or slightly, depending upon the peptide and the way it works once it reaches the cytosol, going inside the cell or even into the nucleolus. So that's fascinating. I mean, of all the things, and there are a bunch of things, I shouldn't pick one or the other, but that's one at the top of the list is exciting, because think of all the different constructs you can make with a Tinker Toy set if you have enough Tinker Toys, right? You go on literally, infinitely, almost literally. And just by tinkering with one of these or two of them or whatever ligands, it changes the way it works. We have the ability to test now, if you look at that with in combination with stem cells where we can grow organs. We can grow a liver, we can grow a pancreas. We don't have to do the human testing or even the animal testing. We go straight to human testing, not in vivo, but in vitro with these, and just start throwing. And of course, then you bring in AI, right? To okay, if this structure does this, based on what we know about all the other structures,
propose some more. Yeah.
Let's see if we make one of these, what happens. And we can really advance pharmacology immensely. And I'm throwing it into pharmacology because, again, a lot of drugs are based on it, insulin being the classic example. And with that, we can not only come up with structures that can enhance the ability of insulin, we've already done it. We have different ways, but what we want to be able to do, for example, is want to have a long-acting insulin. Well, we have those now, Lantus versus the standard insulin, and we can do that with all different kinds of peptides, presumably, and make life a lot easier. We can make them, some we might want to make shorter acting so they're less dangerous. So that's a huge field. And you pick what you're trying to change, we can come up with a peptide for it. I mean, you mentioned the list we have of things that treat everything from libido, right? I remember growing up, I say growing up, I'm 60, but we had this thing, the Spanish fly. Oh, we give somebody extra libido. We have it.
That's the PT-141?
PT-141, yeah.
There you
go. And this is a perfect example. One ligand different, literally one, and it's a great tanning agent.
Wow. Okay. This is fascinating stuff. Yeah. Yeah.
And you go on and on about, for the brain, cerebrolysine, for anxiety, and some call it a nootropic, Cimax. There are different peptides for just about anybody's desire that they want to change.
So at the end of the day, you're saying it's just a protein with fewer than maybe 50 amino acids?
Yeah, really, it's a line they draw, so it's a matter of semantics. But basically, they're amino acids strung together in a certain length and a certain structure. And just I think the general agreement is that if it's 50 or fewer, it's called a peptide. Okay. Although there's some disagreement there. Who cares?
It doesn't matter. Yeah. So then from practical purposes, then what, if you had someone come in, and when would they be a good candidate for peptides? What, kind of a potential issue or goal that they're trying to achieve, maybe if they don't have symptoms yet, going back to your previous statement. And then what would that look like? Are these, pills that they take, injectables, how long they take them? Like, just give us an idea.
So peptides, almost invariably, to get the best effect, certainly you're going to have to inject them because the stomach acid will otherwise denature the structure very quickly. So, although you have studies, for example, that say, okay, that's why you can't take collagen and get benefit, and yet we find that you can take as little as 3 grams of collagen and get some benefit. So the stomach doesn't completely torch it somehow, some way, or maybe it comes back together for some reason we don't know about. But as a general rule, you have to inject these peptides to get them to work. And, that's usually done with a very small needle, an insulin needle, close to you can get 31 gauge as close to an acupuncture needle, which is 36 gauge. The higher the number, the smaller the bore of the needle.
Is right into your stomach or thigh or something like that, right into the muscle?
It's subcutaneously, sorry. Yeah. Yep. Occasionally it can be done intramuscularly as well, but most of the peptides, I think people just kind of get in the habit of doing it subcutaneously. Sometimes for good reason, because you want the uptake to be slower. Sometimes if it's too fast, you can get some flushing with certain of these. But so your question was, what circumstances would you use it? It would be really up to your goals. Now, so there's some that you use insulin where you have a disease state, but let's say for the masters athlete, I call this, right? It's more difficult to put on muscle mass. We use thymosin beta 4, for example, which helps with the generation of actin within the sarcomere.
I'm writing this down. Hold on. Thymosin beta 4. Okay.
Well, and also there's another way, slightly different, TB500. Again, the sky's the limit. It just depends upon what it is you're trying to work on. There's, typically some sort of peptide that works. And the funny thing is, it's not cut and dried like you might expect. insulin works the same for everybody pretty much, right? And you take too much of it, you remove too much glucose and you can die. And some are riskier than others. But then you can have somebody that uses, I'm going to forget, it starts with a D, and I'm not going to remember this one, but it's used to help people sleep. And some people swear by it. Some people doesn't do a doggone thing. Cimex is an anxiolytic. Some people swear by it, doesn't do anything for others. So, is that dose related? We've experimented. I haven't noticed that it makes a difference because dose. Just some people work with certain structures and some people don't. Sermorelin is a classic example. Have you heard of Sermorelin?
No.
So growth hormone releasing hormone, if you take the first 29 amino acids, it's what we call Sermorelin. It used to be branded as Jarrah. Dr. Richard Walker was involved in all that. And it acts the same way. You inject it. It's very short acting, but it makes your body produce more growth hormone. That's what it's for. Mm-hmm. Well, there's a small but significant percentage of those people that when they do it, they get incredible somnolence, such that they have to back down on the dose or survive the next, morning to noon on espressos.
Interesting.
Isn't that?
So, and it's a genetic difference. Like if we peg some of these down to someone's DNA.
Not that I'm aware of. I don't think we've gotten into that kind of nuance just yet, but eventually we can if we do enough studies, particularly if you employ AI. We'll figure out, okay, is there a genetic component there? Is it genetics? Is it epigenetics involved? Is it a combination of, they do this with that? I mean, that's what makes it
it's crazy.
Where AI comes in, not to change the subject, but, it's in the news recently, right?
A lot. We can talk AI for sure.
I don't think we should slow down one bit. I think we might take certain precautions with, using AI in military installations and things that can, drum up, the old, what was it, HAL in space.
HAL 9000, yeah.
Otherwise, let's use it, in medicine because, sky's the limit as to what we can find.
Exactly. Yeah, that is a huge area of potential is in medicine. You were talking earlier about Dr. Google, and I at the time I thought, what about Dr. ChatGPT? Because I've tried using it for things like, I had a little rash on my wrist or something, and I'm like, what could this be? And it says, I'm not a doctor, but here's what the evidence. Of course, they've got all the CYA in there. Well, speaking of the genetics, just real quick, do you do genetic testing at your practice?
Yeah.
Yeah,
I'm a big fan of it, and also epigenetic testing. The DNA methylation testing can give you a lot of good feedback as to what you're doing, the results of what you're doing. Okay, so is it helping? Is it furthering your age, your biological age, or is it helping you be younger for longer? Big proponent of that. While telomeres, I don't think are as helpful. I'd also like to use those.
For aging?
Yeah, I think it's also helpful. It's just not as pinpoint as you might say as DNA methylation. We can get pretty precise with DNA methylation, but it's also nice to look at your genome period, not just the epigenome, to see, okay, what is my propensity? Let's say, God forbid, I've got essential hypertension. I've done everything right. I can't figure it out, but I've got hypertension. Or it's renal artery stenosis, and I don't want to get treatment for it. What drug will work better for me or best for me? Right? We have the relationships mapped out there with certain drugs. Well, or certain categories. Well, you'll do better with a diuretic than an ACE inhibitor. That to me is fascinating too, because especially with critical care, you don't waste time trying something that may or may not work based upon your genes.
That's fascinating. Yeah, no, this is incredible. I mean, you touch on a lot of this in your book. I don't know, I didn't read it in detail, but I browsed it because I just got it a few days ago. I'm assuming the peptides, you go into some detail about the types and what they're for in the book.
Yeah, unlike some of the other books, and one just came out from a guy who I'm a big fan of, Peter Attia, Outlive. And his tells more of a story, I think, and fewer. I'm not going to say there aren't action items, but I tried to go into, for better or for worse, details as to more of those options. Not just peptides can do this, but here's some peptides. As
yes.
Here's a smattering of the peptides, and here's the dose, and And, here are the pharmacies that I recommend, because you don't want to be doing, or I don't suggest that you use, the black market and places that aren't
Right.
qualified to do so. Yeah, when I was 20, I might have done differently. But again, I'm not 20, and I don't recommend it. Do as I say, not as I did. So, yeah, I try and present that in all areas where at the end of the chapter, there's some, I guess you call them action items.
Yep. Yeah, no, I personally appreciate that style of book. It's like a combination, very detailed reference and stories and anecdotes, and it has a positive, optimistic tone to it, which I can appreciate. It's not doom and gloom. It's here's how you can take control. So I just wrap up with a couple last questions, if you don't mind.
Please.
You've probably seen a lot happen in your career, a lot of advancements. We talked about a few of them earlier, and you even said that some of the industry is just catching up. Like you're probably ahead of where a lot of conventional facilities might be. Give us the inside scoop. Like what is coming up maybe that people haven't heard of? What's cutting edge? What's out there that's being developed? I guess besides AI and what we've already talked about.
Well, again, kind of a difficult question to answer, but I'll say it this way. With all the things we have, the areas, like we haven't even touched on gene editing or stem cells. I think what is going to be the most fascinating and one of the most powerful things, it's going to sound kind of anticlimactic, but if you think about it, it's going to be hugely powerful, is the communications between the various specialties, the various disciplines. Mm-hmm. What I mean by that is we touched on a little bit earlier where, okay, we'll use stem cells to grow organs, okay, and AI to develop the right peptides, combine all that to come up with a faster, better working peptide or a drug. We could use drugs, doesn't have to be limited to peptides. What we've been lacking, and it's partly because of the structure, it's not a conspiracy or anything, but the NIH funds projects, okay, and if you're a researcher and someone who wants to advance the sport, so to speak, you're stuck in you're certainly governed by money. And there's only, a limited amount of private funding. The NIH will, I forget what the stats are, but maybe they'll fund maybe 1 in 5, if that's correct. But you also have to be swinging at the same balls, in the sense that if you're pursuing something other than, amyloid plaque for Alzheimer's, well, you're not going to get funded. Well, that limits us. I mean, yeah, you're shaking it like that. You don't have to think about that. Wait a minute, what? Yeah. So we're just.
I'm not surprised though. My cynical brain.
What about all these other areas? And I choose that one purposefully, actually, because we have screwed up on that one. We're now finding that doesn't look like it's the cause. It's really more of the reaction to something that's going on, and we've wasted a lot of time and research, money. Okay, so anyway, without going too far afield, because I am an eternal optimist. Focus on the positive. The future is combining these things and finding groups like one of my peers, Gary Michelson, Milken, the Milken Foundation, and UCLA. They've all gotten together and made it so that they're going to change the way it's funded, so that if you have some, pardon my French, but wild ass idea as to how to fix the problem of Alzheimer's, they're going to say, sounds good. They're going to make a presentation, but here's the funding for it. Not only that, okay, the upshot of that is also that you're not going to be sitting there going like, okay, this is my information. Okay. If I let it go, I'm not going to get funded next year because someone else is going to run with that ball. No, you're going to still get funded by these groups, okay, because that's the approach we want to take. And we're going to share that information with everybody else, so that this hand knows what this hand's doing, et cetera, et cetera. To me, I know it doesn't sound like too exciting, but if you think about it, that's one of the most exciting things about it, where we're going from here, is that we're going to start communicating with one another. Yeah. See some logarithmic changes in our knowledge base.
Yeah, I mean, that's open source. That's crowdsourcing. I mean, you see it in the research in the academic world, where they have like the open access papers, and you have these open databases that all researchers. I mean, all of that stuff is great. Like the more we share, the more we all benefit. So I'm with you there, man.
Yeah. We've been hamstrung because of money, and that's a crummy excuse.
Yeah, no, because it's a perverse incentive.
let's get together and make it a crummy excuse,
Yeah. Well, let's end on one more note here. This is a question I ask all guests. You can't get out of it. And that is,
Okay.
What one question did you wish I had asked? And what is your answer?
Oh, that's a good one. I want to phrase it like more like, okay, if you're a patient, what should you have asked me by now? Wow, man, you got me stumped. I mean, we're yeah. There's so much out there. I don't know what there's so many things you could ask. I mean, I could go on talking about this.
For sure, yeah. There's so many topics in your book I didn't even get to, yeah.
Rand can run the mouth for an indefinite amount of time, at least until he has to eat again. But what to ask me? I don't know. Maybe is there a favorite area I have? That's a kind of a whatever.
Go for it.
Mundane questions. I'm just trying to get out of it because
you're not the only one. This seems to be a stumper. I think it would stump me too.
One of the things we haven't talked about is without my mention is stem cells. Stem cells seem to be stem and muse cells, which is something I mentioned in the book. Muse cells are different than stem cells in that they don't cause cancer. They can cross the blood-brain barrier. They're as or more powerful than stem cells. And until we get some of these other things together and further medicine to the point where we can do it like Star Trek, we know everything's going on. That generates the perfect injection, and then we're done. Stem cells provide a great bridge, stem and muse cells, until we figure out some of the stuff because, I joke a monkey could do it because stem cells know how to home in on the area that needs the help. So you could give these stem or muse cells intravenously and with some general caveats like, okay, the way it's perfused, a lot of these are going to go to the lungs first. But they know where to go. And if you have damage from a recent or even an old MI, a heart attack, those cells will go in there and make some repairs. That's fascinating. And that gives us a lot of time for those that have been injured or will be injured until we come up with even greater advancements in medicines that can dodge those from the start or protect us even more quickly.
I'm all in, Dr. Rand. I mean, all this new stuff, I take something that's called a biologic that wouldn't have existed as little as 5 years ago for a condition I have. And it's just crazy how they can target stuff. So amazing. This has been a fun conversation. Where can people find out more about you? I mentioned the book, but where do you want them to go?
Well, our website, we have a website, psrmed.com. Don't ask me. I came up with that. It's an old story, but Papa Sierra Romeo Med.com. Like to keep a lot of pertinent information up there. I like to stay in touch through Instagram. I found that to be pretty cool through the PR people that I've gotten to know because I can answer questions with that one and then post some tidbits. The world lives in those, a minute to a minute and a half.
The reels.
But we're up on LinkedIn and I think Twitter and Facebook, all those. So, any of those, I guess.
I'll throw it in there, don't worry, and I'll connect with the folks as well, just to make sure it's all good. And this has been a fascinating conversation. I wasn't sure, what we'd get into, and we covered a lot of tangents that were a lot of fun. And you were not long-winded in any way. This was a needed conversation. I'm sure the listener is going to get a lot out of it. So thank you, Dr. Rand, for coming on the show.
Thank you. I appreciate you having me. Thank you very much.
If you've been inspired by today's interview and are ready to take action and build momentum on your health and fitness journey, just schedule a free 30-minute nutrition momentum call with me using the link in my show notes. I promise not to sell or pitch you on anything, but I will help you gain some perspective and guidance so we can get you on the right track toward looking and feeling your best.